Welcome to the deep dive. Today, we are plunging into a world where public health meets poverty, where infrastructure meets infestation, and where a microscopic corkscrew-shaped bacterium causes this massive, but often invisible, global crisis.
That's right.
We are talking about leptospirosis, a globally distributed zoonotic disease often referred to by the dramatic yet, well, pretty accurate nickname of rat fever.
It really is a quintessential example of a modern zoonosis, a disease transmitted from animals to humans where the environment serves as this absolutely indispensable link.
Right.
Our goal today is to give you the complete picture, from the pathogen's unique survival strategy and the, frankly, terrifying symptoms it causes, all the way through to the cutting-edge mathematical modeling researchers are using to design strategies to finally break its tenacious cycle.
Exactly. Our mission is to understand not just what this disease is, but why, despite being treatable and preventable, it remains one of the most widespread zoonotic threats on the planet. We have a robust stack of sources detailing everything from the bacteria's genetics to global infrastructure modeling, and we're going to distill those key insights for you.
And we really have to start with the sheer scale of the problem, because it's frankly staggering, especially for a disease that many people in the Western world have never even heard of.
I'd agree with that.
Leptospirosis is caused by spira-shaped bacteria in the genus Leptospira. And globally, we are talking about roughly 1 million human cases every single year.
1 million.
Which leads to an estimated 60,000 deaths annually.
1 million cases. That number, it really demands attention. So why does it fly under the radar if the mortality rate is that high?
Well, it highlights its highly uneven geographical distribution. While leptospirosis occurs globally, and yes, we do see cases in the United States and Europe, the overwhelming burden is concentrated in very specific areas. It has a significantly higher incidence in tropical climates and in regions, typically low and middle income countries, where poor sanitation and a lack of environmental infrastructure create just perfect conditions for transmission.
The perfect storm. And to add complexity to the agent itself, it's not just one single bug we're fighting, is it?
No, not at all. It's a whole family. There are at least 10 pathogenic species of Leptospira that can cause human disease.
10.
And those species are further divided into more than 250 pathogenic serovars, or distinct variations. So when you are trying to develop diagnostics or, crucially, vaccines, you have to contend with this immense variety, which, as you can imagine, complicates everything.
Okay, let's unpack this core transmission system, which the sources call the core triad. This is what makes leptospirosis so unique because it's not simply person to person.
Precisely. It is fundamentally an animal-borne disease that requires the environment, the water, and the soil as a bridge or maybe a launch pad to infect humans.
A launch pad, I like that.
Yeah, the whole cycle relies on 3 elements interacting. You need infected animals. Those animals must shed the bacteria into contaminated water or soil, and then you need human exposure to that contaminated environment.
So if we can break any one of those connections, if we can clean up the water, vaccinate the animals, or keep people protected, we can stop the human infections.
That's the goal.
That's the goal, and that's what we are trying to understand with this deep dive. So let's start at the source. The pathogen itself. What is this Leptospira bacterium, and how has it mastered the art of survival both inside the host and out in the environment?
Well, Leptospira species are obligate aerobic gram-negative spirochetes.
Okay, that's a mouthful. Let's break that down.
It is. So obligate aerobic just means they need oxygen to survive. Gram-negative refers to their cell wall structure, which has implications for antibiotics.
Right.
And spirochete is the critical part. It describes their shape. If you were to look at them under a microscope, they look like tightly wound corkscrews.
The corkscrew shape isn't just an aesthetic detail, is it? I mean, that's part of their invasion strategy.
Absolutely. That spiral structure allows them to move in a corkscrew, sort of boring or drilling motion. This motility is crucial for penetrating tissue barriers. But their true survival strategy inside the animal host is what ensures their continued transmission.
How so?
They colonize the kidney systems of infected animals. They live very comfortably in the renal tubules and are shed directly into the external environment in the urine of those animals, often without causing the animal any visible distress at all.
That's fascinating. So the host animal essentially becomes a factory for the pathogen, just constantly releasing it. And this isn't just a brief event. The bacteria can thrive outside the host for a while, right?
Right.
Which makes the environment the persistent reservoir.
That's the terrifying part about this disease, especially in areas prone to flooding. Once the bacteria are shed in the urine, They are incredibly tough. They can survive in contaminated freshwater or wet, moist soil for weeks, and sometimes even for months, depending on the temperature and pH levels.
Weeks to months.
Yes. This means the environment, the muddy ground, the open sewer, the stagnant floodwater, becomes the critical, long-lasting reservoir of infection. It's a massive, passive pool of potential infection just waiting for a host.
If they're shed by animals, we need to know which animals. When we hear rat fever, we immediately think rodents, but the sources detail a huge array of animals that act as carriers. It's an incredibly promiscuous pathogen in terms of its host choice.
It is, and this makes control efforts extremely difficult. Virtually all mammals can carry and transmit the bacteria. We are talking about critical livestock, which presents a major economic and food safety problem. Cows, pigs, horses, sheep, and goats.
So all are major farm animals.
All of them. And among domestic animals, dogs are frequently cited carriers, and cats can also transmit it.
And that's before we even get to the wildlife.
Right. Wildlife includes the obvious reservoirs, like rats and mice, the classic agents, but also wild pigs, and even, surprisingly, marine mammals.
Marine mammals.
Yes. Outbreaks have been documented in sea lions and seals, which really highlights that the transmission cycle extends far beyond just land-based reservoirs. It's a very adaptable bug.
The difference between infected animals and infected humans seems to be the crux of why this disease cycle is so incredibly hard to break.
That is the absolute key distinction. Just like humans, many infected animals, especially the primary reservoir hosts like rats, can be completely asymptomatic. They show no signs of illness.
Okay.
However, unlike humans, these reservoir hosts may continue to shed massive amounts of the bacteria into the environment for several months or even for years.
For years.
In some cases, yes. This sustained, silent shedding is what constantly reloads the environmental reservoir, maintaining the disease cycle perpetually, regardless of whether a flood is happening right now or not.
So if we're talking about chronic shedding and lifetime persistence, we have to talk about the primary antagonist in this narrative, particularly in high-burden areas. The urban rat.
We do.
The sources provide a fascinating case study focusing on the Norway rat.
Yes. The Norway rat, Rattus norvegicus, really stands out. Researchers have focused intently on urban slum environments, particularly those studied in places like Salvador, Brazil.
Right.
And in those settings, the Norway rat is identified as the ultimate reservoir for L. interrogans serogroup icterohemorrhagy, which is a major cause of severe, often fatal, human leptospirosis there.
Why does this one rat in this specific environment become such an overwhelmingly effective reservoir? What's the secret sauce?
Well, there are three major factors that combine synergistically in these dense, poor urban settings. First, there is a naturally high prevalence of infection within the rat population itself. They live in close quarters, which facilitates spread among their own species.
Makes sense.
Second, and this is critical for human exposure, they shed a very high concentration of leptospirosis in their urine. They are high-volume pathogen dispersers.
And the third factor is that remarkable longevity of the infection in the rat's body, which you mentioned.
Correct. The sources indicate that these rats appear to have an apparent lifetime of shedding following infection. They become constantly contaminated walking vehicles for the pathogen.
Wow.
So this combination, high prevalence, high concentration, and sustained shedding, turns every infected Norway rat in a dense urban slum into a critical link in the chain.
The sources specifically hammer home the point that in these highly endemic urban areas, the environmental reservoir that contaminated soil and water appears to be maintained solely by the Norway rat population.
It does.
That really defines the scope of the infrastructure and public health challenge, doesn't it?
It absolutely does. It narrows the target, but it also shows the severity of the challenge. In these specific urban environments, human infection is acquired predominantly through contact with open, unlined sewers and soil that is washed down during the seasonal rains or annual flooding.
So the rat isn't biting the human.
No, not at all. The rat is contaminating the ecosystem that the human lives in. The rats create the contamination load, and the lack of proper infrastructure, open sewers, poor drainage, unpaved roads, facilitates the human exposure pathway.
Let's consider the implications of that finding. If the rat is the sole maintainer, then controlling the environment is controlling the rat, but maybe not in the way you might first think. It's less about just killing the rats.
And more about destroying their habitat. Exactly. The source material emphasizes that in these environments, the rat isn't just an incidental carrier, it's the structural foundation of the disease. Any intervention that doesn't address the reason why the rat population thrives Shelter, food, and breeding access in the infrastructure will ultimately fail, which leads us directly into the later discussion on control modeling.
Okay, so moving from the rat and the reservoir to the actual jump across the species barrier, how do humans actually get infected by these microscopic spirochetes? We've established that the environment is the bridge.
Right, so there are three primary routes of transmission detailed in the sources. The overwhelming majority of human infections happen through the first route, indirect contact with water or soil that has been contaminated with infected animal urine or body fluids.
And that's the flooding connection.
That's the flooding connection. This is why we see those devastating spikes during flooding and heavy rainfall. The contamination is just dispersed and mobilized everywhere.
So the environment acts as this massive passive vehicle. What are the other two routes, which I assume are more direct?
They are. The second route is direct contact with body fluids, specifically urine or reproductive fluids, from an infected animal. This primarily affects specific occupational groups: veterinarians, farmers, slaughterhouse workers, people who handle or care for livestock or domestic animals that may be shedding the bacteria.
And the third?
The third route, though much less common, is ingestion. So eating food or drinking water that has been contaminated by animal urine, but the primary focus really remains on that environmental exposure.
Okay, so we know the source is contaminated water or urine, but how does this corkscrew-shaped bacterium get inside the human body? Does it need a massive open wound, or can it penetrate intact skin?
This is where that corkscrew shape becomes critically important. The bacterium is highly motile. It enters the body through abrasions or cuts in the skin, even tiny, unnoticed nicks.
Just a small scrape is enough.
A small scrape is enough. Or, alarmingly, it can enter via the conjunctiva, that's the membrane covering the eye,
Okay.
and other mucous membranes, like in the nose or mouth. It doesn't need to be swallowed, but it doesn't need a large entry point either.
That means even something as common as a small cut on your foot while wading in contaminated water is a wide-open potential entry point.
That's the danger. And the sources point out a specific pervasive risk factor for people dealing with floods or prolonged water contact: skin maceration.
Explain skin maceration for us.
Maceration is the softening or breakdown of the skin that results from prolonged exposure to water. Think about how your hands look after a long bath or washing dishes for hours, wrinkled, soft, and weakened.
Right, right.
When people are standing in floodwater for hours or days, maybe doing cleanup or just trying to navigate their flooded homes, their skin integrity is severely compromised. This softening significantly increases the risk, allowing the spirochetes to penetrate even without a visible deep cut.
So the bacteria basically bore right through that weakened defense.
They do. That immediately relates this threat back to the listener. If you've ever had to clean out a basement or garden extensively after a heavy rain, that compromised skin is the open door this bacterium is looking for.
It completely changes how we view seemingly benign activities in high-risk areas.
It does. And it's also important to reiterate what's rare. While the disease jumps easily from animal to human-to-human transmission is extremely rare. It's primarily been documented only through sexual intercourse and breastfeeding. Animal bites are also noted as a rare, rather than a common, route of infection.
Let's run through the high-risk scenarios and activities because, as you mentioned, the risk isn't static. It is directly linked to environment and activity.
Right, the list really spans recreation, occupation, and disaster recovery. For outdoor recreation, risk increases dramatically during activities like swimming, wading, kayaking, canoeing, rafting, and adventure racing in freshwater sources.
So a lot of popular summer activities.
Exactly. Especially in rivers or streams that are adjacent to farmlands or dense populations. The risk increases exponentially if there is head immersion or swallowing of the water.
The sources reference an outbreak among adventure race participants, which, that really drives home the danger of combining intense physical activity with prolonged exposure to potentially contaminated water.
That specific anecdote highlights the perfect storm. You have a large group of people exerting themselves, they're likely acquiring minor cuts or abrasions, and they're being submerged in natural, untreated fresh water, the ideal environment for the bacteria.
Then you have the occupational side, where prevention is absolutely critical.
The occupational exposure risk is enormous, especially for those working closely with animals or wastewater. This includes veterinarians and vet staff, dairy and farm animal workers, butchers, slaughterhouse workers, and animal control professionals.
But it's not just animal workers.
No, the list extends to municipal workers, like sewage and sanitation employees, first responders involved in disaster or flood recovery, military personnel training in endemic areas, and even people doing everyday outdoor cleaning, maintenance, or gardening in contaminated soil.
And finally, the socio-environmental risk, which we discussed earlier, is what fuels those million annual cases globally.
And this risk is tied directly to poverty and infrastructure deficits. Poor sanitation, the lack of proper waste removal, crowded living conditions in temporary shelters or urban slums, and areas with chronic, heavy rodent infestation. These are the major risk multipliers.
So it all comes back to infrastructure.
It does. If you live in an environment where open sewers are common and the rat population is high, as is the case in urban slums like the one studied in Salvador, the risk of infection is dramatically increased, particularly during the rainy season when the environmental load is washed out into the open. It's an infrastructure failure leading directly to a disease outbreak.
Let's move to the clinical timeline for a person who has been exposed. The incubation period is wide, which must complicate the connection between exposure and illness.
It is very wide, ranging from a short 2 days up to a full month, 30 days. However, typically symptoms will appear about 5 to 14 days after exposure.
So a week or two, usually.
Usually. And it's crucial to stress that many infections are thought to be entirely asymptomatic. The human body just fights it off without the person ever knowing they were infected.
But when a person does become clinically ill, we enter the famous or infamous biphasic illness pattern. The disease essentially hits the patient twice.
That's a very good way to put it. The first phase is the acute nonspecific stage. This is the septicemic phase, where the bacteria are actively circulating in the blood. It affects about 90% of clinical cases and lasts roughly 7 days.
What does this initial stage look and feel like, and why is it so often mistaken for something else?
Well, the symptoms are highly generalized and nonspecific, which is why it's frequently misdiagnosed as severe influenza or dengue or other tropical fevers, especially in endemic areas.
So what would a patient experience?
The patient experiences a sudden high fever, shaking chills, and an incredibly severe headache. This headache is often specifically described as involving photophobia. So, sensitivity to light and retroorbital pain, which means pain behind the eyes.
The sources also mentioned a specific characteristic of the muscle aches, the myalgia, that accompanies this fever.
Yes, the myalgia is a key diagnostic clue. It characteristically involves the large muscles of the calves and the lower back. Patients may also experience nausea, vomiting, diarrhea, abdominal pain, and sometimes a cough. A real grab bag of misery.
It sounds like the worst flu you've ever had. So is there anything that sets it apart in this stage other than the location of the muscle pain?
The one highly characteristic sign, though it doesn't happen in every single case, is something called conjunctival suffusion.
What's that?
What many people would just call red eyes. But unlike regular inflammation or pink eye, the eye looks heavily bloodshot. But there is typically no purulent discharge, no pus. If a patient presents with severe flu-like symptoms, calf myalgia, and intensely red eyes, leptospirosis should be very highly suspected.
Now, this is where the biphasic nature comes in. After this initial week, some people may feel better for a short time. They think they've beaten the flu.
Exactly. They enter a period of temporary resolution. But for 5 to 10% of patients, this is a dangerous lull before the storm. The disease progresses into the immune phase, or the second phase. This stage is characterized by the body starting to produce antibodies, and the leptospires that were in the blood begin to settle in specific target organs, and they also begin appearing in the urine. This is where the severe complications, the multi-organ dysfunction, occur.
And the risk escalates dramatically here. What is the case fatality ratio for those who progress to severe disease?
The case fatality ratio in severe disease is tragically high. It typically ranges from 5 to 15%. This is where the multi-systemic damage unfolds, and it can happen very quickly.
Let's detail those severe complications. Which organs are primarily targeted?
The kidneys and the liver are the two major targets. Severe leptospirosis can rapidly lead to kidney failure, often manifesting as decreased urine output or oliguria. Concurrent with that, you often see severe liver dysfunction, which results in jaundice, the classic yellowing of the skin and eyes.
Beyond the liver and kidneys, what about the central nervous system?
The bacteria can breach the blood-brain barrier, causing inflammation of the membrane around the brain and spinal cord. This is known as meningitis, or often aseptic meningitis. It's usually less severe than bacterial meningitis, but still requires intensive care.
The most critical and arguably the most frightening complication involves the lungs.
Yes, pulmonary involvement is the deadliest aspect of this disease. It leads to pulmonary insufficiency, meaning trouble breathing, and often diffuse alveolar hemorrhage, which is bleeding into the lungs.
Bleeding into the lungs.
Yes. This severe pulmonary hemorrhagic syndrome is a relatively rare complication, but when it occurs, the case fatality ratio is brutal. It often exceeds 50%. It causes rapid, profound respiratory failure.
The disease can also affect the cardiovascular system, correct?
That's right. Patients can develop cardiac arrhythmias, irregular heartbeats, and in the most extreme cases, hemodynamic collapse, where the circulatory system just fails to maintain adequate blood pressure and perfusion to the vital organs.
If you combine the worst-case scenario, renal failure, liver failure, and jaundice, you get the term that doctors traditionally use.
That is Weil syndrome. It is the classically described severe manifestation of leptospirosis, characterized by that combination of renal and liver failure, often accompanied by jaundice and sometimes hemorrhage.
Finally, what does the prognosis look like, and are there groups who are particularly vulnerable to this progression?
Well, poor prognostic indicators include several clinical signs. Older age, any altered mental status which indicates central nervous system involvement, significant respiratory insufficiency, or oliguria.
So decreased urine output is a very bad sign.
A very bad sign. We also know that people with underlying comorbidities like diabetes or pre-existing heart, kidney, or liver disease are far more vulnerable to severe outcomes. Additionally, the sources highlight that contracting leptospirosis during pregnancy carries a high risk of fetal complications, including fetal death or abortion.
Given how quickly this disease can escalate from nonspecific flu symptoms to fatal multi-organ damage, the urgency of both diagnosis and action is paramount. What is the fundamental principle of treating suspected leptospirosis?
The principle is simple. Speed trumps certainty. If leptospirosis is strongly suspected based on the patient's symptoms and their detailed exposure history, did they wade in floodwater? Are they a sanitation worker? Treatment must begin immediately.
Immediately.
You initiate antimicrobial therapy as soon as possible without waiting for the diagnostic test results. We know early intervention is the most effective way to decrease both the severity and the duration of the infection.
So we treat first, but we still need confirmation. Navigating the diagnostic test is a real challenge because, as you mentioned, the bacteria don't stay in one place. We're chasing a ghost in motion.
That's a perfect analogy. The diagnosis is complicated by the transient presence of the bacteria. The tests are timing dependent, and clinicians rely on two different approaches: looking for the organism itself, which is PCR, and looking for the body's defensive footprint, which is serology.
Let's start with PCR, which detects the actual organism's genetic material. When is that most useful?
PCR is a confirmatory test, and it is most helpful during that initial septicemic phase, so roughly the first week of illness, when the bacteria are circulating in high numbers in the blood. The ideal sample then is whole blood, ideally collected within the first 4 days.
So PCR is excellent early on, but once the patient transitions into that immune phase, where do the bacteria go and how does the testing strategy change?
Well, once the first week is passed, the bacteria start to localize in the kidneys and shed into the urine. So urine samples collected after the first week become useful for PCR testing. PCR can also be used on cerebrospinal fluid if the patient is presenting with signs of meningitis.
And then there is serology, which is technically the reference standard for confirmation, but it relies on the body's reaction, which takes time to develop.
That's the catch. Serology detects antibodies, which means its sensitivity increases significantly only after the first week of illness. Specifically when those IgM antibodies start developing, usually between 3 to 10 days after symptom onset.
So the timing is the crucial challenge.
It's absolutely critical to understand that negative serologic results collected in the first week do not rule out the disease. The patient simply hasn't mounted a detectable immune response yet.
So what's the ideal practice for confirmation if the test is so timing dependent?
The ideal practice is to obtain paired acute and convalescent serum samples. That means taking a sample when the patient is first seen in the acute phase, and then taking a second sample 7 to 14 days later in the convalescent phase to look for a 4-fold or greater rise in the antibody titer. That confirms a recent infection.
And what are the different types of serological tests used in practice? I imagine there are simpler ones and more complex ones.
There are. Most laboratories rely on rapid screening tests first. These are often IgM-based commercial assays, like ELISA or Immunodot, which are quick and widely available. However, a positive screening result must always be confirmed by the ultimate reference standard, the microscopic agglutination test, or MAT.
Why is the MAT the gold standard? What makes it so special?
The MAT is the most comprehensive serologic test because it can detect antibodies against multiple different serovars. But it's laborious, it requires live cultures of the bacteria, and it's only available at specialized reference laboratories like the CDC or specific public health labs.
Which explains the difficulty of timely diagnosis in remote or low-resource settings.
Exactly. And finally, for deceased patients, the diagnosis sometimes relies on pathology, using immunohistochemistry on formalin-fixed tissues, with the kidney being the preferred sample due to the bacteria's colonization there.
Moving to the actual treatment protocols, if we suspect it, we start antibiotics right away. What is the distinction in approach between mild and severe cases?
For patients presenting with mild symptoms who can be managed as outpatients, oral antibiotics are used. Doxycycline is the established drug of choice, though alternatives, depending on the patient and potential co-infections, include ampicillin, amoxicillin, or azithromycin.
And if the patient progresses to severe disease like Weil syndrome or severe pulmonary hemorrhage, the approach must change dramatically.
Absolutely. Immediate hospitalization is mandatory, and we switch to intravenous antibiotics. 5-E penicillin G remains the classic drug of choice for severe leptospirosis. However, modern alternatives like 5-E ceftriaxone or cefotaxime are also equally effective and often preferred in contemporary practice due to their broader spectrum and ease of use.
Beyond antibiotics, supportive care is crucial because we are dealing with multi-organ failure. What does that supportive care look like?
It is often the life-saving component. Supportive care involves aggressive fluid and electrolyte management, often including IV hydration and rigorous electrolyte supplementation, especially in patients with severe gastrointestinal losses.
And if the kidneys fail?
If the patient develops oliguric renal failure, where the kidneys stop producing sufficient urine, dialysis may be necessary. And, critically, in cases of respiratory failure or pulmonary hemorrhage, mechanical ventilation is often required to sustain the patient's oxygenation until the infection subsides.
There's one final counterintuitive wrinkle in treatment known as the Jarisch-Herxheimer reaction. You start treating, and the patient momentarily gets worse.
It's often referred to as the treatment paradox in diseases caused by spirochetes, which also includes syphilis and Lyme disease. The Jarisch-Herxheimer reaction is an acute systemic febrile reaction that can occur within the first 24 hours of initiating antibiotic treatment.
What's causing that?
It is essentially an intense inflammatory response, often accompanied by fever, headache, and myalgia, caused by the sudden massive die-off of the bacteria triggered by the antibiotics. Thankfully, it is rarely fatal in leptospirosis, but clinicians must be aware of it to avoid stopping the necessary treatment.
We've established that the enemy is Leptospira, shed by a massive animal reservoir into a favorable environment, the wet soil and floodwater. This gives us clear lines of defense. Let's start with the immediate practical steps for personal and occupational prevention that listeners can implement in high-risk scenarios.
The foundational defense is exposure avoidance. It sounds simple, but it's key. If you are in an area endemic for leptospirosis or dealing with the aftermath of flooding, the rule is simple. Do not swim or wade in potentially contaminated fresh water. Avoid unnecessary contact with muddy water or wet soil, especially if you have broken skin.
And if avoidance isn't possible, as is the case for first responders or people cleaning their homes, robust protective measures are mandatory.
Absolutely. You must cover any cuts, scrapes, or abrasions with waterproof bandages. And critically, you need waterproof personal protective equipment, PPE. We're talking sturdy rubber boots, waders, and heavy-duty gloves for anyone involved in cleaning flood-affected areas, working in agriculture, or handling sewage.
And basic hygiene, I assume?
Non-negotiable. Frequent hand washing and the cleaning and disinfection of any surfaces and equipment that came into contact with contaminated water.
What about water and food safety, especially in a disaster scenario?
This cannot be overstated. After a flood or in an area with poor sanitation, just assume your water sources are contaminated. Always boil or chemically treat potentially contaminated drinking water. For food, strict rodent management is key. Keep rodents away from food preparation areas, store food in trash and closed, non-permeable containers, and utilize effective trapping strategies.
And for farmers or pet owners?
In agricultural settings, prevention involves vaccinating animals, especially dogs and livestock, against leptospirosis and isolating any sick animals to prevent environmental shedding.
We mentioned early intervention with antibiotics. Is there a scenario where people take preventative antibiotics before exposure? This is called chemoprophylaxis.
Yes. The sources note this as an effective but limited tool. Chemoprophylaxis involves taking doxycycline, 200 milligrams orally, on a weekly basis. This regimen is typically started 1 to 2 days before the high-risk exposure begins and continues throughout the duration of the risk period.
Who is this reserved for? It doesn't sound like something for the general public.
No, it is generally reserved for adults facing short-term, intense, high-risk exposures. So think adventure racers entering a jungle area where endemic rates are high, military personnel deploying to high-risk environments, or aid workers entering a recently flooded endemic zone for a defined period.
And I think it's important to mention.
A key point for our listeners in the U.S., though, is that despite vaccines being available for animals, no human vaccine against leptospirosis is currently licensed or available here.
That addresses immediate personal risk. But to truly curb that global burden of 1 million cases, we have to look much bigger, specifically at managing the environment and the animal reservoir. And this is where that mathematical modeling research comes in, analyzing the optimal control dilemma using those urban slums of Salvador, Brazil, as a real-world laboratory.
This research is so critical because it moves beyond reactive public health measures and into predictive economics. The modeling investigates the most efficient way to break the animal-environment-human cycle by balancing the cost of different types of interventions.
Like rat poisoning or sewer installation.
Exactly, against the cost of sustained infection, which includes treatment, hospitalization, lost workdays, and death.
And the central dilemma they explored was binary. Should they focus control on the rat reservoir directly or on controlling the contaminated water and soil environment? They looked at 2 distinct types of measures, temporary and permanent.
Correct. Let's analyze the temporary controls first. These are the immediate reactive actions, applying rodenticide to kill rats, or short-term resource reduction, which means quickly reducing the birth rate by temporarily cleaning up garbage and eliminating obvious food sources.
What did the model show about the long-term effectiveness of these temporary measures when you apply them alone?
The findings were stark. They are fundamentally insufficient for long-term protection. At best, temporary controls only reduce the number of infected rats and leptospires to a low level for a fixed short period. The infection rate plummets initially.
But then it comes right back.
It rapidly recovers.
Why does the rodent population bounce back so swiftly? What are the biological mechanisms at play?
Well, the sources highlight 2 major factors. First, rats exhibit neophobia, a fear of new objects.
Neophobia.
Yeah, this makes them wary of novel things like bait stations or rodenticides, which reduces the uptake and effectiveness of the poison. Second, they have an incredibly rapid reproductive rate. Even if you achieve a massive kill rate, as soon as the pressure is removed, the population quickly reproduces and reaches its previous ecological capacity or carrying capacity very, very fast.
So you spend a huge amount of money on poison and cleanup, but within months, you are right back to square one, with the environmental load of leptospires following soon after. Reactive measures are fundamentally an unsustainable solution.
Precisely. They create a temporary fix, but do not address the structural reasons why the environment supports such a massive, persistent rat population in the first place.
Which leaves us with the permanent controls.
Exactly, which target the environmental structure itself.
But these permanent controls are essentially infrastructure upgrades, which modify the environment to permanently reduce risk.
Yes, and they fall into 2 main categories that attack the problem from different angles. First, you have carrying capacity control, and second, you have leptospire mortality control.
Let's elaborate on carrying capacity control. This seems to be the one that addresses the root cause of the rat problem.
It does. Carrying capacity control means implementing permanent reductions in the habitat suitability for the rats. Examples are crucial here. Permanently closing open sewers, installing proper drainage systems, paving unpaved roads and alleys, and implementing permanent, standardized, covered trash systems.
Things that last.
Exactly. And the modeling results show that high levels of this type of permanent control lead to a sharp, sustained, long-term reduction in the overall rat population size.
Because you're not just killing the rats, you're eliminating their homes, their travel routes, and their food sources all at once.
You are reducing the fundamental resources, the shelter, water, and food that support that large reservoir. This is highly effective long-term because you permanently lower the ceiling of how many rats the environment can even sustain.
And leptospire mortality control attacks the bacteria's environment directly. How does that work?
This targets the survival of the bacteria in the environment. Remember, leptospire thrives in wet, moist soil and stagnant fresh water, away from UV light. So measures here include paving areas to decrease moisture retention and increasing the leptospire's exposure to UV radiation from the sun, which is highly lethal to them.
So you're making the environment itself hostile to the bug.
A permanent way to reduce the environmental load, even if a few rats remain.
Here is where it gets really interesting. The researchers did not find that one method alone was the ultimate answer. They suggested an optimal strategy based on combining these different approaches.
That's the core, high-impact conclusion of the research. The optimal strategy isn't just about infrastructure. It's about timing and sequencing. The modeling suggests that the most effective way to achieve a sustained, low-endemic equilibrium for both the rat population and the leptospires is to combine high levels of permanent environmental controls, specifically carrying capacity reduction, with subsequent temporary measures.
So you build the infrastructure first, and then you hit them with the temporary measures, like a rodenticide campaign.
Exactly. The permanent infrastructure reduces the carrying capacity, making the environment much less suitable. Once the rat population is stressed and reduced due to habitat loss, that is the ideal time to apply a temporary measure, which can then push the population down to a truly low equilibrium that the new, poorer habitat can't sustain for a rebound.
It's an integrated, strategic one-two punch.
It is.
This holistic finding inherently leads us to the broader solution needed for any complex zoonotic disease like this. It requires the One Health approach.
The One Health framework formally acknowledges the intrinsic interconnectedness of human health, animal health, and environmental health. A disease like leptospirosis simply cannot be solved by a Ministry of Health alone, nor by veterinarians alone.
Right.
It requires collaboration across public health, veterinary science, environmental science, sanitation engineering, and even agriculture. A siloed approach misses that critical environmental link.
The sources illustrate this necessity with some compelling international examples of this framework in action.
Indeed. We see this in practice in places like Indonesia, which has piloted integrated rodent and environmental surveillance. They used mapping to identify high-risk areas where rat habitat intersected with human activity, allowing them to focus their rodent control programs not everywhere, but where they mattered most.
And Fiji's strategy highlights the necessity of community buy-in.
Yes, Fiji adopted a community-centered One Health strategy. They involved local leaders to identify specific risk practices within their villages, such as how they stored refuse or specific agricultural practices, and tailored interventions to community needs and traditions. It moved from a top-down mandate to a bottom-up partnership.
Which is always more effective.
Always. And in countries like Thailand and Malaysia, they have institutionalized cross-sectoral coordination, where ministries of health, agriculture, and environment engage in joint planning, combine surveillance systems, and coordinated response activities.
These examples prove that addressing leptospirosis is less about reacting to sick people in the clinic and more about investing in and upgrading the fundamental urban and agricultural infrastructure. It's a critical long-term finding when you're dealing with the disease perpetuated by poor sanitation.
It shows that solving the disease isn't just a medical problem, it's a civil engineering and municipal governance problem.
We have journeyed from the microscopic, corkscrew-shaped spirochete and its tenacious ability to survive in wet soil for months to the staggering global cost of a disease that is so often overlooked.
We have.
We've seen that the biphasic symptoms can range from a severe, nonspecific flu to fatal multi-organ damage, and that diagnosis is a tricky game of timing, relying on PCR early and serology late.
And fundamentally, we've learned the critical takeaway from the research. Temporary reactive measures like scattering rat poison are insufficient for long-term protection in high-risk urban areas. The modeling evidence is absolutely clear.
What's the bottom line?
Sustainable health benefits require permanent structural changes to the environment, closing open sewers, improving drainage, and fundamentally making rat habitats less suitable.
It's a powerful lesson in public health economics. Sometimes the most effective and ultimately most cost-efficient way to save human lives is to invest in infrastructure and environmental quality, leveraging that One Health philosophy to see the whole system at play.
The sources make it undeniably clear that the devastating cycle of leptospirosis is maintained by sustained animal shedding into the environment, particularly during flooding in areas defined by poor sanitation. We have sophisticated models based on real-world data from places like Salvador that identify the optimal long-term interventions, a combination of permanent infrastructure change and strategically timed temporary control.
We know what to do.
We know what to do. So what does it say about our global priorities, our allocation of aid and investment, when we know this combination is the most effective approach to save nearly 60,000 lives annually, Yet this disease continues to affect over 1 million people every year. What stands out to you as the greatest barrier to implementing these structural permanent solutions when we know they work?
A deeply complex question that requires multi-sectoral solutions. Thank you for diving deep with us today.
Until the next deep dive.